Well, thanks so much for being here today, and that was quite a welcome. First, I wanted to say to Mr. President and Ms. Athletics Director, you live in a beautiful part of the country. Your campus is beautiful, and the hospitality is second to none. So thank you very much. We're pleased to be here today. I won't be doing any of the presentation. We're going to leave that up to the expert, Dr. Carol Scott. But I do want to tell a little story to put it in context. When I became athletics director at the University of Nevada, we were woefully understaffed and underprepared to support our student athletes in a medical way, provide the medical care that was needed. And Dr. Scott was a physician at the Student Health Center. And we were just making a transition with our orthopedic staff. And I went to her and asked her and her supervisor if they could help us reform our medical care, provide medical care for our student athletes. Not only did she come in and transform it and serve as our team physician, but she unified the community and the medical care to the tune of about 50 or so physicians to help assist the University of Nevada within the community and built quite a program. Today, she's doing the same thing. She retired from being team physician, went back to the health center, and there is a new team physician that needed mentoring. And the program had kind of slipped since her departure, and so she's doing the same thing today, University of Nevada. Her medical guide, her policy and procedures is used around the country, so I'm pleased to introduce you to her today officially to present to you the best practices in sports medicine. So thanks again for your attention, and anytime you have a question, please raise your hand. I'll come around with the microphone throughout the presentation. So thank you again, and thank you, Idaho State.
Good morning, everyone. Thank you very much for inviting us. This will be a pleasure to talk to you, and this can be informal. If you have questions, we can talk afterwards, we can talk during. I'm happy to answer anything along the way. I'm going to give you a foundation of sports medicine best practices using the NCAA and some other guidelines. We're then going to talk about some of the areas, the pitfalls or places where programs might fall down or have issues, things that you might want to look at in your own program. And then we'll talk a little bit about some conference-specific things. I don't think conference should be making a lot of healthcare policy, but you do have some guidance, and Janie and I talked about that a couple days ago, so we'll review some of those things too. This was more for me than you to get used to your conference and understand a little bit, but it's a big conference with a lot of different geographical locations. The elevation is something that's significant for us in sports medicine. And so that was, like I said, this is just an introductory slide, more for me to learn about your conference. So just in general, why it matters. When student athletes come to us, when all students come to us, we have an institutional duty to protect them and take care of them. In sports medicine, we particularly take care of the student athletes. We would like to prevent all injuries if we can, and that doesn't always happen, but we work on it as much as possible. If they do get injured, we want them back as fast as we can too, right? We want our studies done yesterday. We want surgery tomorrow. But we also want to make it safe. Having sports medicine helps with those type of things. The other thing, and I say this a lot too when I'm working with learners, is taking good care of the student athletes, having good policies and procedures and communication protects the university. So it just falls in line with that. We have protocols that we follow. Our staff is trained. We're going to take good medical care. Bad things can still happen, but hey, we did everything we could with that. We have NCAA compliance that we need to worry about. That often falls under compliance. We have a healthcare administrator that's designated by the institution. And in the fall, when we sign off from sports medicine, we do all these things. Then we give it to the president, who has to trust that we are doing all these things. So that's an important part. Recruitment advantage. We bring our student athletes and parents right into the athletic training room. Look what we're going to do. Look what we're going to do as far as that goes. Student athlete retention, if we keep them healthy. they stay enrolled, they can compete longer, and really medical first leadership. We're going to take care of you first. We know there's pressure to get you back out there, but we're going to make sure you're safe before you go out there. That builds trust in the medical team. Again, we don't have to go through every single one of these individually, but the NCAA does require a number of different foundations and key documents. And independent medical care, we've been talking about this for years now. Independent medical care really means that the medical team, the athletic trainers, the physicians, we have the authority to pull patients off and when to let them back. It can't be administration, it can't be coaching, it has to be medical. Everybody knows we've had concussion safety policies. Mental health best practices is a little bit newer and really important. And having a mental health clinician embedded with us, or the ability to get to somebody right away, somebody that's included in a mental health emergency action plan, has been really significant because it's a big deal, it's common, and it can be really scary for people, including the student athletes. Hey, my friend is suicidal. Do I go to her apartment? Et cetera, et cetera. So having a good mental health best practices standards in your campus is a good thing to do. Cardiac care is important. That's why we have coaches, athletic trainers, administrators that might be in the situation, team physicians. We all need to be trained in CPR. We have automated electronic defibrillators. We ask questions ahead of time on cardiac disease. Do we have a patient coming in who has an issue? Can they play? Are they disqualified? Et cetera. Emergency action plans, really important. Lots of places have them. Lots of places don't practice them or use them frequently enough. Almost always we'll get football to do one. We brought in EMS, we spine boarded, we did all that, but then did volleyball get one this year? Or what about cross country and where are they? So again, important to have those. And then drug testing and compliance, I'm not going to talk about that a lot today. That's a little bit separate, but it is required. And there's some other guidelines. Talk about patient-centered care and supervision. Again, that is looking at the patient and having appropriate supervision for our athletic trainers. I'm not going to go through every single one of these either, but what I want you to know that the athletic trainers, physical therapists, primary care sports medicine team physicians, and orthopedic sports medicine team physicians have put together a toolkit, and they call it the Collegiate Standards of Care Toolkit. You can use this for benchmarking. There are 16 standards. So if you say, hey, let's look through our sports medicine program. Do we meet standards in these areas? Are we doing this? Did we even know we were supposed to do that? So it's a toolkit you can get. It's behind a paywall, but if one of your athletic trainers, your physical therapists, your sports medicine physicians can get it, you can use it as, like I said, as a benchmarking document. Hey, are we going through all these things? Do we do this? Do we have it? Are we looking at it? Medication management is one that really sometimes catches people up. We don't let athletic trainers course prescribe medicines, but depending on the state you're in and what the laws are, there are different regulations on whether they can hand out a Tylenol to somebody or give somebody else an ibuprofen. And the pharmacy boards, the Board of Athletic Trainers, they really look at those kind of things, and they can catch up programs a lot. Again, the cardiovascular consideration, when somebody has sudden cardiac arrest, you really have about 10 minutes to get something going, CPR, defibrillation. So being sure that we have a program, we have an AED nearby, we have people trained, we can at least bridge the gap to now the ambulance gets here, now we go to the hospital. And then the pre-participation, the annual, and the exit physicals. We are required to take care of the student athletes for 2 years after they are done playing sports. And so those exit physicals are really important because if somebody does have something and they don't have an exit physical, it's not documented, it's hard to come back later and say, oh, my shoulder injury happened during softball, but I didn't ever have an exit physical. So you really want to, on those exit physicals, I know they're ready to get out of here, you're ready to get them out of here. but important that we do those. Mentioned behavioral and mental health. The screening and referral part, we are required to do screening now. Typically, schools would do that in the beginning of the season, but you may want to do it again after a major injury. We pay a lot of attention to, oh gosh, we got to take care of the ACL, but we need to pay a little bit more attention to how does the student athlete feel about that? Do they want to go back to play, or can we, or et cetera? So behavioral and mental health is a big part of things. Nutrition, body composition, having someone on campus that can help you with that. Again, another evolving thing that's really important. And then what we do the most is the musculoskeletal and return to play. And this is where your athletic trainers really are the workhorses in this area. And they're doing a lot of that. You may have a physical therapist involved, and if you don't, and you have an opportunity to do that, it's great to have one. They help us with some of the more complicated issues, some of the post-op stuff. Is that better? Okay. Maybe not. All right, a couple more things that they have in here. Student athlete performance and wellness, and focusing on holistic health and overall health for our student athletes. Yes, budgets are in there, healthcare administration, oversight of the sports medicine department. Stakeholder education, this is where we tell our student athletes, or we tell our coaches, hey, this is the new guidance, this is what we want you to look for, this is what we want you to be aware of. Here are symptoms of concussion. If you feel those, please come talk to us. This is what we want to do if a student athlete has sickle cell trait or some other medical condition. Maybe they have diabetes. We want them to be able to be educated on that, and we want to educate our coaches and anyone else that's working with them at the time. And then we want them to have safe, accessible treatment in the facility. So those are collegiate standards of care that you can get, like you said, and use as a benchmarking. Equity is embedded through a lot of this. And it's not just the men get this and the women get that. It might be my track athlete gets an MRI in 2 weeks, but my football athlete gets one the next day. So I have to be a little bit careful about those type of things. As far as some of your policies and procedures, and one of our athletic trainers here helped us with our pregnancy policy. Thank you. And we included men in that because they're partners too. And they may need time off to go to an appointment. They may need time off after, they have a child. So looking through it, it's like I said, it's not just a male-female thing. We want them to have access to safe environments. Does one team have to practice in the cold with no place to get warm while the other one has heated benches, et cetera, et cetera. So equity falls through all of it. Okay, so where might we have some gaps and some problems here? Having a single athletic trainer cover multiple sports simultaneously is a big problem because if something happens at one venue and they're really across campus at another one, that can be a big deal. We don't have somebody there, so I know we don't always have enough staffing, or they're spread out, or a new game came up, or something got scheduled differently, but if in general it's common that you just have one athletic trainer covering a couple sports at the same time, that may be something that you want to adjust. Budget cuts all over the place, right? And some of the GA level athletic training positions being eliminated. The athletic trainers went from a bachelor's to a master's program a few years ago. They say they're still putting out as many, but some of those GA positions that they used to come out with a bachelor's and have a internship are gone. The electronic medical record is a problem too. When when we did the Affordable Care Act, electronic medical records were supposed to be able to talk to each other. And the truth is they don't. I use 3 in my everyday work now. But having an EMR that's not set up for athletic training staff is hard because a lot of times they don't have access to that. They aren't able to use it as well. It doesn't do an injury. It's not set up for athletic training use. And what happens is then I'm just too busy at the end of the day. And I know I have 10 more people I have to put into the injury report, but I got to go home. And so, gee, we may not get that. We may not have records. And you know now how the transfer portal is, right? So I'll get a patient in, yeah, I had an MRI on my hip. Where is it? Can't find it. We can't get the medical records. We end up doing it over. It's not great for medical care. So when you're considering, hey, what are we using for our athletic training staff? Or is there an add-on to whatever we're using at the student health center, at the primary care sports medicine docs that you're working with? It may be something that you want to address. And they're getting better and better as far as what they will do for athletic trainers, and they can save a lot of time in terms of things like injury reports and documentation referrals. And then the portal volume is overwhelming for us sometimes. You know, in January now, it's changed now with football, but it would be, we got 35 guys coming in the day after New Year's, and can we do all those physicals in one day? And that's, like I said, that overwhelms your athletic trainers in your department too. You got to get your physicians in there as well. So portal volume, portal, we'd be happy to see a change. Yeah, you got it.
Is there a role in there in this current environment for the sports medical professionals to have some ability to review those incoming prospects? What does that look like? Is it even feasible? Have you done that? Yes, it's feasible. You can do it. It's legal. The NCAA lets you. I can bring you in as a transfer. You know, what we do is we tell our coaches, don't sign them yet. And get them to do that. And then they can come, and on their visit, we can do a history and physical. We can even do some diagnostic type testing. We don't really send them off to the MRI, but our orthopedic surgeons can look. You can't do any performance type testing, like, gee, go run the 40 and we'll see how that goes. But you can do all that. And then what we do is we will do a recruiting physical, and we've got a score at the bottom. And 0 is, you know, no problem, and 5 is, it's going to be a problem if we assign this person. We can request medical records before, so you can implement that in there. It's a little bit hard logistically if you're getting someone from Florida who has to come for a recruiting visit, you know what I mean, like that. But yeah, you can. We can just request records. And you can say, hey, would you look over this volleyball player before coach signs him? What do you think? And we would say, this one's probably, you know, looks like, depending on what kind of information we can get, looks okay, or gee, we wouldn't recommend this. Now, sometimes coaches don't sign it, but at least you have a little bit of process in place where you can head some of that stuff off. There are people who don't report things to us. Came in and said one concussion on a recruiting physical, and then got there and we've got records, and now they've had 6. So there are some people who don't play for us either, and they've already signed. But yeah, you can do those recruiting physicals. You may not need to do it on everybody, but it's possible and it's legal to do that.
So as you, and I know you've been in a number of places where you've done reviews and things, are you seeing that function is becoming, you know, part of your agreements with your healthcare provider, with your partnership organization, that, you know, it wouldn't just be our campus team physician, but are you seeing that, is that something that should go in an RFP, that the physicians at our partner organization will be recruiting physicals or reviews, or has that been a pay-for-service kind of a function?
Most of the time it is the team physicians that are doing it. If our orthopedic surgeons are around and are able, but again, sometimes if they're there at noon and those guys are in surgery, et cetera, but yeah, it can be part of that. And if you have somebody who's local or not too far away, come back, you can do that. Yeah, so more places are doing that because technically the schools have 2 years that they're supposed to be taking care of it. But what happens in real life is we sign them, they're ours, and we take over their ACL rehab, they're 7 months in. And now those are our bills and going forward. So to try to go back to the previous school and say, hey, pay for this rehab at our facility for the next, it just doesn't happen very often. It's, you know, it's one
one of those things that you probably could, but the hassle of it and trying to get it done doesn't. So. And yeah, go ahead.
So is that on coaches to come and talk to athletic trainers about if they're recruiting someone that is coming in with an injury? Because most of the time it's, we don't know that they're coming in
Right.
with an injury.
That would be a
beforehand.
conversation ahead of time. Hey, this is your window. Who are you bringing in? Would you like us to do these recruiting physicals for you? And they don't take that long. Honestly, our athletic trainers hand them the history form, and then they hand them to me. So they're not really even doing a lot of that. And then I'll look at them, or we'll have, our physical therapist or someone like that. As long as you're just doing things diagnostically, not, like I said, testing any kind of sports performance. But with transfer portal, and we get students who were at a bigger school and got an injury and are coming to our school, and so we get a lot of people who are coming in with injuries and problems, and it can be hard to determine, hey, who's going to do great, who's not, and we're wrong sometimes. But at least you have, if you have that set up and your coaches know, hey, give us a score. Tell us, what do you think about this one or that one? I can tell you sometimes I'm like, this person will never play for us. Never. Don't even do that. Or, hey, this is great. This person's going to be fine. And then everything, there's the gray issues in the middle. No physician or limited team physician. I don't know. I don't know your conference well enough to know if that's an issue. I do know, especially in smaller places, that sometimes you don't have 6 primary care sports medicines. You don't have every orthopedic specialist. And are we sending them here? Are we sending them there? And what happens when our one team physician gets sick and can't travel to the football game? Do we have a backup or not? So not having a physician or a limited team physician can be a problem.
Athletic trainers, more administrative duties, all those new physicals, more compliance responsibilities adds on to their administration. Really, really common are the emergency action plans and that they're missing or they're not updated, or we've moved where we practice and softball still says we practice, not picking. Softball still says we practice over here, or gee, cross country now has a meet here. We're using a public center instead of our typical place. Are you ready if something happens there? When you look back at some of the student athlete deaths through the years, it hasn't been that they haven't had their AED or they haven't had CPR and they haven't had that. It's that they moved where practice was. They called and said, football practice, we need you here. Ambulance goes to the wrong place. The gate's locked, can't get in, obstructions in the way. So particularly when something like that is happening, athletic training staff, get your antenna up. If something happened, does someone have a key to the gate? Can you, et cetera. And then I don't want to pick on the coaches too much, but I will a little bit because this still happens. And it shouldn't. We try to get them back as fast as we can. We're not going to put them out there if they're not ready. We also pride ourselves on, hey, we got them back. We can put him in a cast, and my defensive back loves it that he has a club and he can hit the ball. But coaches, if there's undue influence or really interfering with that process, we need a feedback mechanism for athletic to have someone in administration to get. And for you in the Big Sky, you do have some unique geographic isolation in the level 1 trauma center. That can be significant if something happens and you're far away from that specialty care. The altitude is a big deal too, depending on your student athletes. If you're a student athlete who's always lived at sea level, now lives at sea level, let's just say I have asthma and I have sickle cell trait, not a disease condition where under low oxygen
Cells can sickle or change their size, and then they can block blood flow to all the important organs. And altitude makes that a lot worse. So, like I said, if I'm at a place, we are at close to 5,000 feet, so we don't worry about that. But when we do have
teams coming from other places with no sickle cell trait student athletes, we will have oxygen on the sideline. We will alert EMS, hey, just in case. So that altitude variation is a big deal, not just for they're in better shape than we are because they've been training at 7,000 feet, but what happens if one of our student athletes has some type of a condition made worse? Everybody, wildfire smoke, right? That's just such a headache. And do we want to cancel a football game? No. Do we want to cancel soccer? No. Do we not let cross-country run? No, but this impacts a lot of schools in extreme cold as well. Again, you may have student athletes who are coming from places where they've never been in that kind of cold, and some of your campuses are regularly really cold. Limited conference cold weather policy isn't a bad thing. What that means is the conference does have policies for certain sports, but not every single one. And when that happens, we revert to what's the NCAA guidance, which is fine. NCAA guidance, though, may not be specific enough for your school. So we talk about that a little bit more later on. But if you think, hey, we need something else for cold, you can create a policy, an NCAA policy. You can reference the conference says, for softball, if it's 30 degrees real feel, we stop that sport. We do this for football. And so if you think you need something like that, you can create that in conjunction with what your conference covers. We talked a little bit about the physician coverage gaps, and that's real. And physicians get tired and burned out and don't want to travel or aren't available. You know, if you have one orthopedic surgeon and his daughter's getting married next weekend and now you don't have anybody because you don't have a backup, that can be an issue. And then AT workforce shortage. Everybody's looking for athletic trainers right now. There aren't enough of you. There probably are, but they don't want to come to my school. So anyway, you know, it's harder. And they do work a lot, and they don't get paid a lot, and it can be a difficult profession. Some of them earlier on in their career might work for us, and we hope that they become great athletic trainers, but then sometimes that means they leave. And we don't like that part. So here's a couple of the areas that are big areas. The conditioning without acclimatization, and I don't know if you've heard of rhabdomyolysis before, but that's a breakdown of the muscle from. This happens when, hey, we've come back from 6 weeks off, got in trouble, and coach said you're going to do a lot of punishment. With or without sickle cell trait, that can be a life-threatening. The sickle cell trait problem, addressed that for a lot of years now, and it still happens. A lot of the issue is communication. They are required to be tested for all of our students. Cell trait tests. Then we know about it as athletic trainers, but do we have a policy that says coach needs to know? Does strength and conditioning coach need to know? Because that's where things can happen. Does the student athlete know? Tell them. When you start to feel like this, do this. You know, this is the issue. This does not and should not impede your sports performance, but if you start to get in trouble, please stop. And, you know, they're brand new and want to make the team and want to show coach how good they are, and they keep pushing and pushing, or coach keeps pushing and pushing. And it's kind of this perfect storm of, and that can be fatal. Same thing, we talked about emergency action plans on file, but we never rehearsed them. If you're a sport that it's just you, the athletic trainer, with cardiac arrest, you need the coach to help you. So when you do your emergency action plan, you know, tennis coach, I need you to be in on this plan and know what to do. Equipment's not available, not working, you know, the AED is the nightmare. And I had an AED brought to me, I called for it, I was in the conference center, I didn't check it ahead of time. They brought it to me, but it didn't have any pads. Well, you have to put pads on to shock. So I was like, the only thing I can do is whack them over the chest with the AED. So you want to make sure that not only is your equipment there, you check it ahead of time. So guess what? I check every single AED when I respond. Let me look at it. Does it have what I need? Medications aren't available or expired. Hey, we can only afford one EpiPen because they're $400 a piece, and we used it on a track athlete yesterday, and now one of our softball players needs it. Haven't replaced it. We don't have that emergency medication that we need. So
So backups for those kind of things. Seems easy, but somebody needs to look at it and check it and make sure it's not expired, it's working, batteries aren't dead. And then controlled air quality, not paying attention, not watching. Somebody has to monitor those things before during activity. Before, if you hit one of those measurements that says, hey, we can't do this, then there has to be some kind of a chain of command for, we can't do this. So at the conference level, you have that. Practice, sometimes that may not happen. So again, you just want to have something in place, guidance that says, if this, then that.
This is an older study from 2019. It was a Chronicle of Higher Education, and they actually did an anonymous survey of the athletic trainers, and 52% of them said they thought coaches were inappropriately interfering with medical care decisions. My sense is I think this is getting better, but it's something we still want to talk about and still make sure we're not letting that happen in many cases. Again, single AT has 2 sports and someone gets injured at the other sport. And then the mental health issue is big too. And again, your student athlete discloses her title.
The teammate doesn't know what to do, who to call, calls your athletic trainer. I don't know who to call. Do we have a mental health person that can help us with this? Or do we have some kind of emergency action plan for the mental health issues? And these are happening more and more. So we want that nailed down too. What do we do? Is it campus security? Is it campus police? Is it local EMS? Is there somebody that knows? I don't want our athletic trainers or coaches, going over there to try to solve that kind of a crisis. That's not their area of expertise. So if they know, hey, here's clear guidance, here's what we do, it makes it a lot smoother. Yep.
Our emergency action plans, because I know we have them, we go over them, but probably not as often as we should. What's your recommendation?
So annually is what the NCAA recommends, but then I think it's at your comfort level. A lot of times places will go over it in the summer and then maybe right before season again, especially if something's changed. We practice, but we have a different coach now, or we have a different athletic trainer, et cetera, et cetera. Folks who are maybe less experienced in their career, or coaches who haven't done it before. So again, depends on, it's recommended at least annually, but some places will do it more often than that, probably every 6 months if you really wanted to be good. And along those lines, you need to document that you did those and get them to compliance. Hey, we did these, and someone can check and say, did all of our teams do an emergency action plan this year? Athletic trainers. I couldn't find exact numbers for your salary here. I know that for us, we're oftentimes a little bit less than the national average, but 58,000 isn't a lot for a master's level profession. A lot of times they'll work more than 60 hours a week. There are times when there's downtime, but that's becoming less and less these days. Some programs will have a joint athletic trainer, occupational therapy, doctor of physical therapy program, and when our athletic trainers are in those programs, sometimes they go, I don't have to be somewhere on nights and weekends and I make a whole lot more money, so those sometimes are taking away some of our athletic trainers. And in the mixed guide, which is common for our conference as well, the tenure is about 3 to 5 years for various reasons. But you have a lot of training and investment and institutional knowledge in those folks, so it's tough when we lose them. And why we're losing them. And some of this is from the athletic training literature, but compensation certainly. The communication gaps, I want to have clear communication with my coach. Coaches can be intimidating, especially if you're early on in your career. And if you don't know who to go to help, or just something's not going well, and I'm not getting some help with that, those unclear expectations and communication gaps, it just makes you feel like you're not as a appreciated or autonomous or in charge, and people who feel like that's an issue for them. Again, when we graduate students from medical school, they're not ready to practice on their own. We have to go through 3 to 8 more years where we're actually in some kind of a mentorship program. Maybe you don't need that long for your athletic trainers, but when someone comes in who's just out of the training program, maybe pairing them with somebody who has a little more experience that can help them, guide them, they know who to go to. And so you can actually do a formal pairing with that. Career advancement, again, depends on your organization, your structure, but is there an opportunity for me to go from an assistant to an associate, or can I oversee this or that? And it might not even be, hey, you're going to go to an associate. It might be, well, we're going to actually have you do this limited additional job, and maybe we give you a couple thousand a year extra, not, you're not looking at a whole. But it's another way to retain them. Work hours, it's tough, especially during season. And I do want to just address this out-of-season demand with no off-season, because this is getting worse for us. And, the 2 sports that I've noticed the most this year are our softball and our soccer. And so we've got softball games in the fall when our soccer trainer and athletic trainer is covering, and vice versa. So those folks really don't have an off-season anymore like it used to be. Soccer's over, it's December, we're doing a little bit in the spring, and then we're getting going again in August, and now we might have a couple, 3 or 4 games. And did you say there was a recommendation for soccer to go half and half? So soccer, a limited fall schedule and a limited spring schedule. I don't know if that's passed or where that is, but then our soccer athletic trainers will be breaking out. And football is just year-round all the time. It's just, there's no, there might be a day where we don't have football on campus. So that's, again, it used to be you had a season, and then really communication and having someone you can go to for support. It may be your head athletic trainer, it may be somebody else that you designated, but somebody to help when things aren't going well, or what do I do, or I'm having trouble with the coach, and giving some support. So you can certainly look at compensation.
Can I ask you a really quick question?
Yeah, you can ask.
Because, you're nailing exactly what's happening on every campus, at least on our campus, with all this, and finding people that are good. In your experience, are there things we can help our athletic trainers stop doing that maybe they've done in the past that gets them to be more efficient now? Like, are there any things, or maybe think about that, or maybe the answer is no. But are there things that in 2020 or even 2016, like you don't need to do those things anymore now in 2026. We can now focus on other things.
I think that the electronic medical record would be huge. If I can spend 10 minutes putting in my injury report versus 2 hours, and then I send a Google Doc to a coach, and then he has to sign into Google to get it. And if I can't get the MRI report, I'll be a surgeon the next day. So doing a little bit more electronically. And I'll give you an example. Ron has been helping with this too at Idaho State, but we do a screening in the fall and other times on the mental health. So we'll use 2 forms. One's a PHQ-9, one's a GAD-7. They evaluate for depression and anxiety. It's a paper form. I hand it to you, fill out the paper form. Athletic trainer looks at it, scores it, or just goes right to the mental health person. Now someone has a stack of 300 pieces of paper. All these student athletes, how do we have to see mental health? Who said they're suicidal? We track down right away, et cetera, et cetera. Our EMR that we use is, and I don't work for these people, but we use SmarterBase AMS, it's with Teamworks. They can put that in, we hand the student athlete a tablet, it gets scored, it shows up on my screen. Carol Scott scored a 17. I better find Ron Inslee and say, hey, can you help with this? Or in the case of I scored high on the suicidal question, it texts me. It says, hey, you need to go find Carol Scott and get her in. She scored high on this. So those kind of things that take away that 300 pages to look through. So and there are different apps out there. There are different kinds of electronic medical There are some that will integrate with what you have. Teamworks is the big deal. It's like Epic in medicine, you know, it's taken over everything. It's expensive, but it can save a lot of time. And having that, I don't have to write this new injury report every night. I don't have to mail it out to everybody and change it. They don't look at it because they don't want to get it versus click, it's out there. And this other stuff too. So I think that's a big deal.
What about insurance management?
Student insurance coordinator, yeah. And if you have one of your athletic trainers doing it, give them a little extra money to do it, because nobody likes that. But an insurance coordinator is super helpful. Some of these EMRs, do your billing. Smartbase, gives you administrator, depending on what you're using. So getting into that kind of thing. There's an investment up front. But then after everybody has to learn it, you have to do another EMR, et cetera, But once you get that going, super helpful.
I mean, I recognize AI is not going to help somebody who's in cardiac arrest. But are there AI tools, and again, we can talk about some of that later, but that can make our athletic trainers' lives more efficient in how that they can get to the practice of this?
So in your electronic medical record, again, you can use templates. So, I'm doing the same thing for a student athlete with an ankle for 2 weeks in a row, or just a little tiny bit of a change. You put the template in, and then at the bottom, the condition is a little bit different. So, yeah, a lot of that can help with that. Being there on the sideline, having to watch things, filling out, those will always be a human job. So again, look at your ratios. If you have 4 athletic trainers for 400 student athletes, that's not great. If you can get, 1 or 2 more in there, or even more than that. But look at, there are numbers, the National Association of Athletic Trainers puts out numbers, things that they say this would be a recommendation for college athletes. We talked a little bit before, the mentoring culture, parent experience, athletic trainer, and your staff. The other piece of that is having learners in your system. And so if you have an athletic training program, a master's in athletic training program, you also learn from teaching. So our younger our more less experienced athletic trainers, hey, now I'm teaching some of the students that come through, and okay, I've taught the same ankle exam for 40 times now, but now I'm really good at it. So it's not just mentoring, but having them do some teaching too, if there's time and that fits, or you have that kind of can you have some kind of a promotion ladder, retention incentives, some of those type of things you can think about. Hey, we can't afford any of that, but we'll send you to a conference and you can learn dry needling and get certified, and that will help us. And gee, maybe that costs $400 instead of $10,000. Protecting the athletic training staff from the coaching pressure is really important. I said it, I think it's better, but when you don't have autonomy, or coach is always like, we're going to do this instead, or I'm going to send them there, or I want them to see someone else, that's hard on you as a professional. Like, I wanted to be the one to take care of this. And vice versa, if you have an athletic trainer who's not, holding up their part of the bargain, having a way for the coaches to talk about that too, and intervene before it goes way too far down the line and now we're really having a problem. And when you can, have schedules where we say you're covering this, and we know this is your off time, versus, oh, we just lost the track and field athletic trainer, now you're traveling to San Diego, I know you just finished, with golf or whatever. So when you can, when it can be predictable,
Scheduling, and it's starting to feel like maybe in leagues like ours, schools like ours, it's not like it's feasible to hire enough athletic trainers to have one for each sport.
right.
And so you think, okay, that's not feasible for us to have 15. It's also not feasible from a medical standpoint to have one athletic trainer really assigned to 2 sports. It just never quite works out. What are the 2 perfect sports to marry under one athletic trainer? So are you seeing any scheduling models, and I'm thinking, gosh, could we use AI for this, that are building schedules where it isn't just one athletic trainer per team, it might be a combination of these 2. Are there models where that's effective? Because we always hear how important that student athlete to this athletic trainer, I know what I'm comfortable with, I know that's an important relationship. work to shape that up for better coverage?
A little bit, and if you're lucky enough to have a sports medicine fellowship program, we don't let the fellows do things by themselves in the first part of the year, but we will on the second part, and that person can be at some of those things too. But what some of the athletic training staffs will do is what they call zone coverage. So if you're not here, I know you're my zone partner, or we're gonna both be there that day and be back and forth and that kind of thing. So again, that's something you can make at, I've let the athletic trainers make that. But there are more than one person assigned to this, and when you're gone, I cover yours, or et cetera. And then as far as the scheduling goes, if we've got a football game, and gosh, volleyball and soccer both got scheduled, all at the same time, I mean, some of that too, you can look at a master schedule through the year and look at some of those. Hey, soccer has a spring game, but my athletic trainer's on softball, and they have a game too. That can be something that you look at either in terms of scheduling, or who's my partner, who's my team, my zone defense, if you will, type of a thing. So people are looking at different things like that. Sometimes you hire a per diem for some of those type of things. Again, they're expensive typically, but we don't have somebody and we really have, somebody's out sick, somebody's gone for some reason, those are some backups that we have. For coaches, hey, medical needs to do medical, you coach. If you're having a recurrent problem, we want you to back up your athletic trainers again. So if it's the athletic trainer who's the problem, we want to wait for the coaches to give some feedback too, without undermining each other right there in front of everybody in the athletic training. You can do that, Daniel, and you probably do this already, but a check-in. How did it go? How was the athletic? Where could we? And if that can be a conversation instead of a headbutting, it's better. But this happens sometimes too, and it might be that you're stuck with each other. I mean, this is an arranged marriage. We don't have anybody else, so do we need to get a counselor in here to help you to figure out how to work through this? But check in, and when you have a new hire, I feel like at least a month to 6 weeks in, or earlier depending, check in with both of them. How's it going? What do we need to change? What do we need to do? Again, before, now it's to the end of the season, and we're never going to work with each other again. And then I'm just going to mention the dual report structure, because this is something that you see schools doing. And the dual report structure is, typically it's been team physician, head athletic trainer, takes on all the athletic training staff. And we have limited connection to administration. The dual report structure is team physician, admin, much like a sport admin person, athletic training staff. So now we have a place for the admin part when there's a problem with a coach. I'm usually not the one going and saying, coach, you have to, at least I don't want to be. We've got the admin side for that. Medical problem, medical evaluation, we've got the team physician and that structure that follows. So places that are doing that, and I actually work under that now, I really like it. It does mean that someone in your administrative staff has to learn a little bit more about sports medicine, but it's not that hard. They don't have to be medical provider, they don't have to know everything, but we've got a little bit better connection, a little bit more of an umbrella, and a couple of people to talk to if things aren't going well. So and I think Cary's worked with some schools who are doing that too. Just a quick, do you have, and this whole slide can be, do you have a chain of command in place? So catastrophic incident happens. Athletic trainer, head athletic trainer, is it team physician, is it administration? Does your athletic director call the president? Does the president call the board of control or board of regents or whatever? I mean, how does that go? Do you have that in place? Telephone tree, are those numbers updated? Who calls the student athlete's family? When I'm in Montana and I don't have their emergency contact information, and they might not make it. Who is doing that? How do you have that set up? So, and who can you talk to between FERPA and HIPAA? Is there something on file? And then once this happens, really need to sit down, do a full documentation case review. What went well, what didn't go well, what could we have done, what do we need to do? But again, if you have something in place ahead of time, and it's gotta go all the way up the chain, you know, if it's, you know, one of our student athletes died, it gets to Cary, she's gotta go up, where is she going? You know, is it president next, is it the vice president, you know, et cetera. So have that in place ahead of time. It just makes it so much easier with communication, and particularly somebody talking to the student athlete's family. Who's designated to do that? You know, should it be an athletic director? Should it be a physician? Probably not the athletic trainer, is it the head athletic trainer? So have some kind of a communication catastrophic tree in place with current numbers or ways to get a hold of people. I put this in because, again, we talked about it a little bit before, but Dustin Enzinger, who's the head athletic trainer at Idaho State, said, hey, we've got this with the conference, but I'd really like to have something in place. Again, the NCAA gives us guidance, it doesn't give really a clear policy, so you can make that if you want or think that you need that. The one thing I'm going to mention here with heat, with cold, and with air quality is you've got to have some kind of a system to monitor it. And a lot of times we have an app, and I can look at my app, but my app is across, 10 miles away over here in Pocatello, and it's not on campus in Idaho. So there are those things out there. Maybe on your campus you have atmospheric sciences, maybe you have an environmental science, maybe you have somebody who wants to put an air quality, heat, cold gauge right on your stadium or on your track or whatever. Hey, you can do a little research on temperatures, you can let us in on that. You can find some ways to collaborate on that, but you just have to make sure where is it measuring and what's it measuring, and if it's 20 miles away, that might not be accurate. I brought this one up too. Did you have some problems with that this year? Anybody?
I always have this problem.
We do too. We do too. And again, you want to see where are you measuring it? What are you measuring? What are you using? Is it airnow.gov? Is it purple air, et cetera, et cetera? And I just wanted you to, the number 2, and this is appropriate. The Big Sky Conference uses the NCAA guidance. That's what we're supposed to do. But 300 plus is a really bad air quality. It's terrible. And so what happens is, at least in Washoe County, all the high schools, all the grade schools, all the junior highs shut down, and our soccer team's out there playing. People call and go, why does Nevada get to, well, they shut down at 200, and we shut down at 300. But again, postponing or canceling a big game is a big deal. So it's not that we should change that. I just want you to be aware when people call to complain, you're letting your team out. We are following guidance. But 300 is really bad. If you can move something indoor or change something, it would be good to do so. And again, you would have your host athletic trainer as the monitor. If you have the ability to establish indoor alternatives before the smoke begins, and that might even be for practice. Some schools have the dome or the indoor facilities. If it's going to be a big deal, hey, we're in the 270-80 range, you better start talking to each other ahead of time, because that can be bad when you show up and go, hey, guess what, we just went to 307 and the stands are full. And then for our athletic trainers, student athletes with things like sickle cell or asthma, we may need to modify them in those kind of situations. So these are just some suggestions. You don't have to do any of this, but the campus risk profile, campus has a health and safety, conference has a health and safety committee. Maybe you say this year we want to know who's doing emergency action plans and having practice with them. So you can send a little 5-question survey, and do we have something then we can offer some guidance? Can we share our template for that? Or, hey, somebody has a great sickle cell policy or a great concussion policy, could we share that? When there's a catastrophic event, some places will actually have an incident reporting, and kind of a shared loop of this happened. Again, we have to de-identify that, but this happened at our university, and it's possible that yours, et cetera, et cetera. Maybe you have a conference-wide minimum standard for this is what we need for cardiac, this is what we need for EAT, or not. These are things if your health and safety committee wants to do that. You can say, hey, what are your policies? Let's just see what they are, especially if we're going to use a host school policy for some of this stuff. And And then having the regular meetings of the health and safety committee, and I know we've done concussion, but you can do some of these other things too, especially if you see something that comes up in your conference. And at the campus level, again, we want to know where we're going and if we're taking people to 7,000-foot elevation from 25. I always ask, where's the nearest trauma center? What would we do if I have to send a student athlete to the trauma center and it's 100 miles away? Who on my staff, administration, is someone going to drive there? I can't send my athletic trainer by. Somebody's got to go over there, talk to the family. It was, so it can get complicated. Support for athletic trainers. Communication chain before injuries or catastrophic things happen, because it's just, it gets really complicated when something like that happens and no one knows who do I call next, or that person's gone, that's not your phone number. I don't know, provost very well, how do I find out who they are, et cetera, et cetera. You can share conference structure, share the standard, mutual aid. You know what, our orthopedic physician can't travel, can we borrow yours? And I've definitely done this before. I'd be on the sideline, hey, I don't have an orthopedic surgeon today. If something bad happens, can I borrow you? And all the physicians, at least in my experience, have been, of course, we'll be happy to, but let us know ahead of time, let's not. If you have a standard, is everyone using it? A written protocol should be in place before the season and reviewed. Coach medical boundary, talked about that probably too much. And then the documentation, when we talked about some of the electronic medical records and the documentation and taking some of that off the plate. So what could you do? Look at your school, just look at your campus sports medicine program. You can even use the toolkit or something else. Hey, are things updated? Are we in line? Do we have things? And if it can't be anything else, is practice your emergency action plans, make sure that your equipment works, and have some kind of a communication crisis guided ways. Again, this is, you can use it for advisory or shared protocols. You have a health and safety committee. You want everybody to know about X, Y, Z. And then what we're doing right now. Commissioner coming up here, maybe there's some type of a sports medicine update when things change or at when meetings. Any more questions? Questions about things? Yeah.
So, like our health and, where's Janie at? Hi, Janie. So our health and safety committee that Janie leads from the conference office staff. So, it wasn't activated much, then COVID hit, and then Janie's now has a doctorate, honorary doctorate of sports medicine from that.
Yep.
So, what are you seeing out there from kind of best practices from a conference perspective around what topics? I guess, I hate scheduling a meeting just to schedule a meeting to say our sports medicine committee, health and safety committee meeting met. Well, great, what do we do? Is it worth our time? And what can we do meaningful? So are you seeing things out there from a conference perspective that are meaningful to the trainers, that are meaningful to the coaches? I guess I'm looking for something that if we're going to invest the time and energy of our conference personnel, I want it to be worthwhile.
So if you've had catastrophic incidents and things like that, that may be an educational thing. But what you can also do is, it's a 5-question survey where, what would you like to hear, what would you like to know, did something come up this year? And you may not have something all the time. Or, people want to know how the mental health emergency action plan works. People want to know what we're doing with this. What about the portal physical? So finding out what would be specific for your conference. So I would say the first thing to do would be to, ask and survey some of them. And it may be athletic training, sports medicine staff, it may be administrators. Say what's out there, what's happening. Did we have anything happen this year that we should talk about? So I've tried to get some information first. There's lots of things that come out on the NCAA level. Nothing that's earth-shattering right now. We're pretty much in line with. I think everybody's got their concussion policy, and basically don't do that over and over and over. But when again, when things go wrong, the emergency action stuff, and the emergency preparedness is always a big deal, so is everybody up to speed on that little piece? No, okay, here's some recommendations.
If I could just add something, we're working with some conferences right now, and they have a similar committee structure. And so I can get you some examples.
That'd be great.
I'll do a follow-up with you and send you some information. Patriot League, Big West, we just worked with them on some things, Big South. And they all have similar committees, but they're doing that. Big Ten, they do a little different structure, but I'm happy to send that to you.
That'd be great, Carrie.
You bet.
Yeah, thank you.
Yeah, I try to get information on what people want to know or hear about, or if something comes up. Anybody else have any other questions?
What about outsourcing? And just partnering with a local medical provider, they provide the trainer. I mean, are you seeing more of that? You saw that trend and kind of, what are the pitfalls and positives? What do you think?
So the pitfall is the communication and not having them there all the time. If they are in your local sports medicine group or orthopedic group has them, that can be fine too. You don't have as much control over that. It tends to, the outsourcing, I think it's mostly, it's not our program, it's somebody else's, and what we're going to do and how we're going to do that. It tends to be more expensive, depending on who you're working with, but that happens. Sometimes that's what you have, depending on where you are, what resources you have.
I can add one more thing to that too. Just finished working with the school that outsourced for strength and for athletic training. And they're discontinuing that because it's 8 to 5. And you're not going to get them to follow up on anything, any other part of that day. And so they're discontinuing. And so this whole issue with the lack of athletic trainers out there, schools have tried to outsource, even with compliance services, you're seeing that now as well, but it's not working as well as they got it. So
You're seeing a trend of kind of, I think there was kind of a rush, not a rush,
It
but
was.
it was a popular thing. You look at your budget, San Joaquin spending $1.2 million on
That's
this
right.
entire enterprise. And can I just give somebody $1 million and go do it?
That's
But
right.
you're finding that trend now coming back.
We are.
Okay.
And not only is it coming back because it wasn't good for us, they are realizing, they thought they were getting a lot of surgeries out of this deal, and, gee, we got 10 a year, which I would be thrilled with, but, they're like, well, that's not even 2 weeks for us, so it's not worth our money to do that, and the high schools do that a lot too, one of the groups will put athletic training in the high schools, and honestly, all the time, it's more of a community service than a money maker for them. And so when they start looking at their budgets, it's like, why are we doing that? We're losing a lot of money. We aren't getting 100 surgeries a year from Idaho State. So they are also pulling back on it.
Carol, have you seen, I know you review a lot of RFPs and the contracts between institutions and their sports medicine partner. Is athletic training ever getting worked in that? Because these are really coveted contracts. They do want all of Idaho State surgeries. That seems like it's all they want, right?
Yes.
Are you having luck or seeing anybody work in a certain amount of PRN athletic training services? All of our potential partners have athletic trainers out for contract. They send to high schools or wherever, the Pocatello Marathon. Are you seeing anyone put that in an RFP as, we don't want your full-time athletic trainer, but we want X number of hours of PRNs available? Is that something you see success with?
You can, again, we, athletic trainers, team physicians, we're a pretty close-knit group. So someone who comes in has to know, a lot of those kind of things. You can do that, but I don't see it very often. Most of the time, the athletic trainers are employed by the university in some form or fashion. But, definitely on the RFPs and positions, if you have the ability to not have an exclusive contract, that's an important piece because you really get locked in there. Hey, we want to go to the foot and ankle person over here because they don't have one, et cetera, et cetera. But a lot of those athletic trainers are working at the high school level already. Per diem, you have some that that come in and train with our athletic trainers and lead some here and there coverage. That could be, it's certainly something you can discuss. I just don't see it a lot.
With those PRNs, it will, again, the same institution that put those in their contract for the hospital and their orthopedic care. Got to be very specific on what you want them for. And it's your choice and not their choice. We're gonna, once we give you X number of hours, many of them don't want to be off campus. They don't want to do weekends. So you got to be very specific because that's where some of the challenges are. You ever seen a model, sorry, I have all these.
You're
words,
good, go ahead.
Where you don't just have one sports medicine. It isn't just, the Phoenix Medical Center that is your partner, but then maybe you have a couple because there's not enough professionals at one. Any of those marriages ever work out?
Yes, that's what we did. I grabbed a couple of primary care from here and here. I got 3 different orthopedic groups, and you have to work together for us. You're our hand, you're our this, you're our that. And we set it up ahead of time that way. This is what we want from you. We're not going to be exclusive. We're not going here, here, and here. And then we grew to, even more people in the community without that. You're that hospital and you're that hospital. It's like, we're going to work together. We did have people who agreed to do that. And, it depends on the groups and the politics. So it could be something that works really well, or no way. We only want to be exclusive and that's it. And sometimes that's what you have. You don't have all the choices. But yeah, it can be that, hey, we want to use these 2 doctors in this group and we want to use that one from that group. And we do that right now. We have our hospital and I'm employed by the university and we have different orthopedic surgeons that we use. Sometimes it's just saying this is, but I will tell you, especially in orthopedics, the politics, in Reno, we have too many orthopedic surgeons, so they're the only one being the only ones, and it's gotten harder than it used to be. But yeah, it can work if you set that expectation up front. We want you, and you, and you, and, I don't know a lot about the marketing and the advertising and the this and that you all do, but those are, incentives sometimes too. We work with both hospitals. They're both on our football field, that kind of thing. It can work, but it has to take some conversations up front and expectations. And, but yeah, we've done that.
All right, any more questions? No. Let's give Carol and Cary a round of applause.